much. I'd like to introduce our next speaker, Dr. Doug Bruce. He's a chief of medicine at Cornell Scott Hill Health Center and the associate clinical professor of medicine at Yale School of Medicine, an investigator at the Clinical and Health Sciences Research Corps, CIRA. Dr. Bruce's interests reside at the intersection of substance abuse and dependence and infectious diseases, particularly HIV and hepatitis C. We are pleased to welcome him for his presentation, Chronic Pain and Opioid Use. Thank you, Dr. Bruce.
Thank you very much. All right. Good afternoon, everybody. Thanks so much for spending the last day with me as we talk about everyone's favorite topic, pain and opioid use. And I have no financial affiliations to disclose. And the learning objectives, some of the things that we're going to be talking about today, which and all of these slides will be available to everyone. There are going to be several questions throughout this. We're not actually going to be doing polling today. We're really just going to, I want you to think about what your response would be, but in the interest of time, we'll keep it moving. So one of the things that I want you all to think about is in this conversation we have this afternoon is how confident do you really feel about managing chronic non-malignant pain? And we're slicing out here non-malignant, meaning this is not cancer pain. This is pain from other causes. So pain is something that is really rampant within HIV clinical settings. People with HIV tend to report a greater proportion of being either untreated or undertreated than people with cancer. In particular, when you look at various cohorts, having HIV, being a woman, having a history of injecting drugs makes it less likely that a person would receive pain treatment. And so it's interesting, but these different groups of individuals, for reasons that are probably disparate, are biased against in access to pain treatment. So something that we all need to really get our heads around is that pain is really, really complicated. We want it to be very simple. Our patients want it to be simple, but it's really, really complicated. So even if you have an obvious organic cause for pain, pain is perceived or experienced differently. And so I tell people it's kind of like looking through a different pair of glasses, right? So you're looking at the same object, but if we swap glasses, my prescription's different. You're going to see it differently. And so part of that is by the multiple factors that we know influence pain. So one of them is depression, psychological distress, PTSD. These tend to increase pain. Drug abuse, certainly. Sleep disturbances, all stressors will increase pain, both physical and emotional stressors. We know that other things such as HIV therapy, healthcare use, missing HIV clinical visits, all of these can be influenced by either having pain or by attempts to get pain controlled. Unemployment is a huge stressor, and so it'll increase pain. And then there are a lack of protective psychological factors. So we know that if you have a supportive social system, for example, you have people that care about you and that look after you, that actually helps you cope better with pain. It doesn't make your pain go away, but it helps you cope better. So I know this may seem elementary, but I have continued to be amazed at the number of people that were sent to me that never had a real history or physical exam, but had a pain diagnosis and were actually on opioids. So, when somebody comes to you with pain, because pain is subjective, the first thing that we do is we validate the complaint of pain. I'm really sorry that your back hurts. Okay, let's talk about your back pain. And what becomes really important is that detailed history and a physical examination, right? So we always start with a history and physical, and then we move to a diagnostic workup. And that's really important because we don't want to just either make assumptions about the etiology of the pain, which often happens. We also don't want to just do a shotgun approach and say, well, I'll order an MRI of your back. Unless you see actual nerve impingement with actual physical exam demonstrating that specific neural impingement. An MRI of your back is pretty abnormal in most people with HIV, and that doesn't necessarily explain pain. And a good back surgeon is not going to operate without any kind of exact understanding of what's going on, because oftentimes the pain doesn't get better, and then you have post-operative pain and things are worse. In the population I care for, everyone gets a psychiatric evaluation, and we do a risk for addiction. The psychiatric evaluation, as I tell patients, even if you didn't have major depression or anxiety before, people who have pain are going to be anxious and depressed, right? You're anxious about what will bring more pain. you're depressed because you're living with chronic pain. Treatment plan should be comprehensive, and you certainly need to be monitoring pain treatment as you go on. So this is a real patient. He was a gentleman who had heroin. He was a heroin injector. He was on methadone maintenance. He got opioids from his primary care provider, and he was having more back pain. And so basically they just assumed that he was drug seeking, wanted more pain meds to sell them. And so they didn't give him any more pain meds and didn't really do anything else and sent him to me. So the question obviously is, well, what would you do? I have had people say that they would definitely pretend to be sick and avoid seeing the patient. But what you want to do, right, is you actually want to take a history and do a physical exam. And so when you do that, you find out that, of course, he's had this lumbar back pain for years, but in the last 6 weeks, he's got a new pain in a new area. You examine him, you find that he's got a region in his thoracic vertebra that's new, pinpoint tenderness, 6 weeks duration. You say, you know what? I'm going to get an MRI. You get an MRI, and as the slides say, yep, that's bad. The patient wound up having a discitis that resulted in the need for surgery and long-term antibiotics. And again, this was missed. The patient was complaining of pain, but the issue was that the healthcare provider assumed, didn't do a history, didn't do a physical, just assumed, drug addict, pain, drug seeking. And that's a really bad assumption to be making. So several of these slides I'm going to move through rather quickly, and that's because these slides are available for you. And these aren't complicated principles. They're very, very, I think we've laid them out well. And I think as you practice them, that's where the real piece is. So when you're doing a history, there are just a couple things that you want to focus on. And the first one is a pain scale without a reference is meaningless. If I say the pain is an 8, that has no bearing. You don't know what that means. I have to reference to something. So if I tell you, well, for me, stubbing my toe is a 5, and so I'm like 3 above that, that's very different than the patient who says, yeah, a 5 for me is when I broke my femur in a motorcycle accident, right? Like completely different, same number, completely different. So you got to have a frame of reference. In the world that we're in, that frame of reference tends not to be something numerical, but it tends to be ADLs. So how far can you walk before your knee pain hurts so much that you're not able to continue walking but have to stop? You know, can you pick up your grandchild? Can you pick up your groceries? What are the ADLs that become a little bit more quantitative and then help you monitor treatment, right? You obviously want to know what other past workups were going on. And obviously if the patient's jumping from a provider, you want to know why. There's always a story there. It's always important that you talk about not just the person's past substance use, but their family substance use, right? And it's also important to talk about alcohol, right? I'm amazed at the number of people who will come in, oh, this person has no history of drug use. You talk to the guy for 5 minutes, you find out that he was binge drinking when he was in high school. But those are important pieces of information. You can use screening tools, the Assist, Audit, DAST, KJ, they're all open source. If you do them for everybody. You don't want to be profiling individuals. And then also just be mindful that you can have pain in certain parts of your body, and they may actually be an alarm for something else. I had a patient with chronic rectal pain who'd been a victim of violence, and he had this very, very long and expensive workup, and there was no organic disease found. And they were getting ready to invoke a very rare, like 3 people in the country have ever had this syndrome. And that's when, you know, a well-timed conversation got into the history of sexual assault. And that's what ended up being the etiology. Examination is obvious. You're going to actually look at the area, look at the range of motion, again, impact on ADLs. I continually get referrals of people who have back pain or on narcotics, and I can't find in the notes an examination of the back. If you're thinking about giving controlled substances for something, you should have done an examination. And the key, obviously, is if you document everything, when you talk to the DEA, they don't smile, and they often want to see the documentation. A lot of what we're talking today is from this paper. This is the IAS-USA guideline on chronic non-malignant pain in patients living with HIV. There's an online, if you follow the link there, it's about 100 pages. Everything is in greater detail. And can get into the weeds on many of the things we're talking about. So something that people often don't talk about because nobody pays for it is, although therapy may be paid for, may be difficult to access, CBT is cognitive behavioral therapy. But acupuncture has been found to be helpful with chronic non-malignant pain, and yoga has been found to help improvement, which I always find interesting. Having tried yoga, it's very difficult. Because pain is not just biological, organic, it's perception. That's why it's always so important to make sure that people are connected to behavioral health. In our world, that's a prescriber like a psych APRN or psychiatrist, a therapist, case management, other forms of therapy, certainly peer support are all really important in helping people address this complicated disorder. It's always important to have people agree, right? So we have a pain management structure that has one provider and one clinic do the medications. We should make sure that the person's connected to the psychiatric evaluations. In our world, we use contingency management, both for addiction treatment and pain treatment. So you might get a week's worth of medication to get you to your next appointment, which might be with a therapist, it might be with pharmacy, it might be with somebody else. Again, it's linking you to the people that need to connect you. If people are, people get urine toxins, random pill counts, we'll talk more about that. And if people are actively using drugs, that doesn't necessarily mean we stop pain treatment, but it certainly means you need to go into a drug program. If you don't go into a drug program, we're not going to continue pain treatment. Jessica Merlin and colleagues did a very interesting study looking at chronic long-term opioid treatment, virologic failure. And I think there's some interesting things in the study. For our purposes today, I think one of the most important things to remember is that long-term opioid treatment didn't impact retention. And I have heard providers tell me constantly, I'm not really sure he's taking all the pills, but it's keeping him in treatment. And here's a study that's examined that and found that, yeah, we're all remembering the patients that fit our narrative. Yeah, Johnny kept coming back, but we forgot all the other patients who didn't, right? So don't use long-term opioids simply to retain people in care. Only use long-term opioids if needed for a disorder, a pain disorder that you've diagnosed through history examination and other diagnostic workup. So it's very important to remember that pain resolution is not necessarily the goal of treatment, right? Again, it's back because for some of our patients that has to be unconscious, right? An improvement in your ADL. You wanted to walk 2 blocks, now you can walk 2 blocks. You don't need more pain meds, you're actually achieving the goal you're looking for. So when we talk to patients, we're looking at those functional goals. Can you pick up your groceries now? Can you pick up your grandchild now? Can you walk those 2 blocks, 3 blocks, quarter mile, whatever you're trying to do? How is it affecting your quality of life? Are you feeling as hopeless as you were? You also want to monitor for adverse events, right? And adherence. Are people diverting? Are they taking their medication? What's going on? Do people have Narcan at home? Are they sure that they have other forms of medications? Certainly, if opioids are involved, you got to have a treatment agreement. There's a lot more about that in the IDSA guideline, and you want to think about urine drug testing. So as we think about urine drug testing, it's really important to know that you need to screen everybody. And the reason is because patients are really good at hiding illicit substance use, right? And I know it's amazing the number of people who always say, no, I can tell who uses drugs. You can tell the obvious people, but there are a lot of very, very clever people out there. And so just as you would monitor AST and ALT for someone taking atorvastatin, you should be monitoring somebody either with a urine drug screen or some other form of testing to make sure that the person is not having an adverse event. And an adverse event includes diversion. Make sure that when you're using a urine drug screen, you know what it screens for. So oxycodone screens for oxycodone. Opiates don't screen for oxycodone. And also know what a false positive might pop up. So for example, ciprofloxacin can confuse some immunoassays into thinking that they're opiates. So here's another just little quick vignette. So you get a patient, he comes in, he's on a bunch of oxys. In Connecticut, the total you can get in a month is 240 tablets. He hasn't had a urine tox a long time, and there he is. He's got methamphetamines in his urine, and of course he's struggling to sit still. You wonders why the refill takes so long. And there are a lot of things that you could think about doing, right? Obviously, you could curse the provider, you could give the refill and just try never to see him again. You could try and pawn him off on somebody else. And you could talk with the patient about the ED visit, the methamphetamine, and you could refill the medication, or you could not refill the medication. So as you're thinking about that, one key piece of information I did not provide you is whether or not the urine tox also showed oxycodone. If the patient showed oxycodone, then you know he's actually taking it. Maybe he has two disorders, methamphetamine and a pain disorder that he takes the oxycodone for. If there's no oxycodone in his urine, then maybe he's just selling the oxycodone and using it. Those aren't exact, but that's another important thing to be factoring in. Often in our situation, if he was taking the oxycodone, we would refill the medication, but it would be limited and it would be a refill that connects him to drug treatment. If he's unwilling to do drug treatment, we would taper him off the medication. So obviously, if a urine drug test you do isn't matching, you should obviously, did the patient's meds run out? Do they have more pain? And that's why. Do they have a false positive or negative urine? It's always important when you see a patient, before you do a urine tox, to always ask the patient when was their last dose, and you want to document that, especially if you're doing a send-out test. Because when you see that patient again weeks later, you want to be able to say, hey, you know, you told me that you had actually taken meds the day before and the day of our appointment, but your urine tox was negative. So either you lied to me then or you're lying to me now. Either way, that's really problematic. Just when people do start to have aberrant behavior, it can mean lots of things. It could mean the pain's not treated, poor coping skills, drug use relapse. We're going to zip through Amanda here because I want to get to addiction. And addiction is what Amanda was struggling with, right? She shows up and she has morphine in her urine. And what she did is she sold her oxycodone, bought heroin, which is cheaper, and she's using that. And why is she using that? Why does she have an addiction? Well, she has a behavior that's reinforcing it feels good, but she's lost control. She can't stop. If a heroin user can stop on their own, then they don't have an addiction problem, right? And there are people like that. There are people that can quit cigarettes cold turkey, they can quit cocaine cold turkey, and they can quit opioids cold turkey. There are not a lot of them. Why do people take drugs? Well, so some people it's to feel good. For most of my patients, honestly, it's to feel better, to lessen their anxiety, their worries, their fears. So many of our patients are victims of sexual violence or physical violence, and that PTSD, which is an anxiety disorder, often is driving people to want to feel better. And so what ends up happening is a drug co-opts some of the brain circuits that are really your normal motivational priority. So for example, we're hardwired that food is good, you should eat. But if you've ever met a methamphetamine user or cocaine user or someone, a lot of them are like really skinny. Well, why is that? Because amphetamines, cocaine, opioids are a better neurobiological reward. If you've got $10 and you could buy a sandwich or you could buy a bag of dope, if you're dope sick, you're going to buy that bag of dope, right? Because it's more important to you and how you feel. And that becomes really important. If people are going to turn down food for drugs and you're coming in trying to convince somebody to do something else for their health, it can be a very difficult argument to persuade somebody. It's important that just in general to treat all patients with dignity and respect. I know that all of you who are involved in caring for people in the Ryan White community are really the hallmarks of people who do that. And I have great respect for the work that you're doing. People who use drugs are people. And I really encourage people not to take malingering manipulation. Personally, it's all a survival mechanism. People are trying to survive. Don't take it personally. Just very practically, right? So find a screening tool. There are lots of screening tools out there. These are two in the slides that have been validated. Think about systems. So when you start screening, you got to think about what you're going to do. Ideally, you want to have a low threshold. That means it's rapid access. It's easy for someone to get services from you. If it's easier to get drugs than it is to get help from you, the person's going to go get drugs. Make sure that you have access to some form of counseling. It could be as simple as Narcotics Anonymous. It could be more complicated. There's no data to show that NA is better than CBT. Counseling is counseling. You want to find something that people are willing to engage in. You want to treat everyone, provide naloxone, make sure because of the overdose risk, make sure that the medical consequences of addiction, HIV, Hep C, Hep B, all of those are treated, and make sure that you really take a step back, because oftentimes patients are in this change process And you may be more motivated to help them get sober than they are. So we talked a little bit in one of the QA sessions this week. There's a book, Nudge, by Richard Thaler and Cass Sunstein. And it's more in the economics world and decision theory, but it has incredible implications for what we do in healthcare and about nudging people patiently towards better health outcomes. Again, make sure you have naloxone. Learn a little bit more about motivational interviewing and rolling with resistance. Don't take it personally. Be supportive. And you'll find that patients may not change immediately like you want them to, but people do change over time. The life cycle of a heroin user is really horrible. The little tick marks below are heroin use, and you can see initially in drug use, people are feeling euphoria. Later, they're just feeling sick. And then what ends up happening is overdose. And this is from the 1960s, and unfortunately, things haven't changed much. These are the medications that are FDA approved for the treatment of opioid use disorder: methadone, buprenorphine, and naltrexone. If someone's on methadone, that's the little M. It will wind up stabilizing the opioid receptors. If someone uses, they don't feel euphoria. When somebody comes in and maybe they've relapsed to drugs, they have a positive drug screen, make sure that you continue to provide treatment for those individuals, right? Just because somebody comes in and has a positive urine tox doesn't mean that it's actually time to kick them to the curb. Oftentimes our patients have more than just I mean, heroin use disorder is a horrible thing that people have to deal with. But oftentimes they have other things. Early on, we said that patients oftentimes will have some kind of other thing that's driving them to self-medicate to try to feel better. And we found that oftentimes doing a mental health evaluation really allows people to kind of start teasing that out, right? We know that mental health disorders are more prevalent in HIV clinical settings. It's even more prevalent among people who use drugs. Mental health disorders can complicate pain treatment, can complicate addiction. Make sure that you're screening people. The PHQ-2, which is a 2-question and a subset of the PHQ-9, is a great screening tool, but make sure that you're looking for it. If you don't look for it, you're not going to find it. It's always important just to remember as we wrap up that pain and addiction, unfortunately, can go together, but that doesn't mean that they are the same thing. Remember, HIV is a proxy for risk-taking. Addiction is a proxy for risk-taking as well. And people who take more risk wind up falling off a roof because they're intoxicated. They wind up crashing a motor vehicle. They wind up walking out into traffic and getting hit. And those can lead to chronic pain. But getting hit by a car or crashing doesn't stop the prior addiction. It only added a new problem, pain. So we don't want to think about this as, okay, it's all the same thing. It's not. There are different systems going on. And so this is why it's so important to have a team that can help sort this out, but also can help support the patient and the provider during that time of trying to sort out what to do and how to engage patients. But the most important thing is don't just kick someone off pain treatment that they may need just because they have another problem. Just like you don't stop diabetic meds because the patient didn't take their high blood pressure meds. So again, as we wrap up, we all are, I think, terrified of the patient coming in with aberrant behavior, who's calling all the time, who's yelling, who's inappropriate to the staff. And the truth here is that all of these things can actually cause aberrant behavior. It could be addiction. Pseudo-addiction is just the pain wasn't treated enough, and so the person actually wound up behaving like a substance user when they're not. But metabolic conditions, infectious diseases, mental health disorders, the important thing here is patients struggling with addiction can be difficult, obviously. But as healthcare providers, it's our responsibility to look past that, not take that personally, and make sure that we're not missing something. Because before you discharge a patient from the clinic, you really want to make sure that you didn't just miss depression masquerading itself through aberrant behavior and increasing pain, and then that person goes out and commits suicide. Make sure that you have access to somebody who knows more about addiction if you need help in mental health and pain management. Obviously, you can't always get those everywhere you want them. However, there are either through hospital systems or academic centers, there are online systems. I mentioned the IAS-USA guideline, the American Pain Society, and others have great resources available. You're not alone. There are a lot of people out there who can help. Here are a bunch of the websites that you can also take a look at. This is both for pain treatment, or the top two, American Academy of Pain, the American Pain Society, and the bottom two, the Provider Clinical Support System and the buprenorphine trainings. If you have not become a buprenorphine prescriber yet, I strongly encourage you to do that. And the reason I encourage you to do that is it's an office-based tool that allows you to provide care for patients who come in who are struggling. And as we wrap up, I will just tell you about the time when I was in the office. I was just there charting, and somebody came and said, "Oh, you know, this guy just showed up. He just got out of prison and he needs help." And I said, "Wow, what does he need help with? Blah, blah, blah." Okay, he just got out of prison. He's a heroin user. He's really worried about relapse. We were actually able to, in that moment, nobody in the clinic could prescribe buprenorphine but me. I just happened to be there because I was behind on charting and had to chart more, and wound up being able to talk with this gentleman, connect him to buprenorphine. And that wound up being a very long-term sobriety road for him. He can engage in counseling, became kind of a model citizen, and with his probation officer and all kinds of folks. And even later, I had patients, you know, new people coming up to me saying, hey, whatever he got, can I have? Because like no one ever thought he could get sober. And that all happened because I just happened to be the guy who knew how to prescribe buprenorphine and just happened to be at the right place at the right time. You want to make sure that you have the tools to do that, so that if somebody walks in the door and needs help, you have the ability to help that individual. So I think we're supposed to move into the Q&A time, and I'm going to stop broadcasting my screen.
Perfect. Thank you so much, Dr. Bruce. That was really very helpful talk, and I have several questions here from the audience.
Fire away.
So in multiple of your slides, you really highlighted the importance of getting behavioral health involved. Many providers agree with that recommendation. However, given that there's a lack of availability for behavioral health providers, either counselors or prescribers, not just in rural areas, but even in metropolitan underserved areas. What's your access to getting patients into psychiatric care as soon as possible? And if people don't have the access to behavioral health, or let's say patients are not willing to go and see those people because of COVID concerns, are you aware of any virtual or online services available, or other recommendations you might have to address that specific need?
Great question. So what we actually did in our environment is we actually just created a behavioral health environment. And we actually had to do that in New Haven. Yale's outpatient psychiatry is more research focused and not clinically oriented towards the community. And so we actually wound up creating a clinic over many years. And now there are multiple psychiatrists and 100 therapists and all kinds of things. What I encourage people to do actually is start learning some of the tools. You can learn basic motivational interviewing and basic CBT. Now, you don't want to get into seeking safety and trauma and all that stuff. But look, I'm an internist, right? But I've learned all of this over the years. And part of that's because so much of what's important is engagement and trust. And then if you can find somebody in your community, a psych APRN or a psychiatrist, who's also willing to kind of mentor you along and support you, that can be incredibly helpful. So, for example, I mean, primary care providers will always be the first line for mental health care in America. We're not going to have enough mental health providers. So learn the basics to help people engage, and then find some people that you can work with. And that may not actually be somebody even in your community. There's all kinds of resources in the COVID world. So much has gone virtual. This entire conference is virtual, something we would have never thought before. In our environment, we bought these $50 Amazon Fire things, and I gave them to the homeless department, our street medicine team, to go out into the streets so they could actually do video visits with therapists, because there's just no way I could get the therapist out the street. It's just too complicated and too costly. So I would say be creative. There's going to be somebody in your state who might be very interested in supporting what you're doing. Get creative, send some messages out, use social media. You'll find some help.
Great, thank you. So what are your thoughts about medicinal cannabis or CBD oil? Are you aware of data? What's your approach?
Absolutely. So obviously there are legal issues regarding the use of cannabis, right? So it's federally illegal, but states have legalized it. So we do know that cannabis use will decrease the opioids that people use. So we don't know why, but I've seen it, where people were using more oxycodone, they start using some cannabis, and then they will be able to decrease their opioid requirement. The balance is really just trying to help make sure that people aren't in a fog, right? So you're not living life if you can't remember what's going on because you've been smoking cannabis all day. You're not living life if you're suffering in pain. So we'll use it in the right patient. You got to make sure that if the person's in drug treatment or other things, also if parole officers are involved, you got to make sure that people are aware. And but yeah, we also worry about, anytime you inhale any form of smoke in your lungs, it's bad for your lungs. So CBD oil might be actually a better way to ingest it. But yeah, there's data that works. So some of the data has issues with it, but I've certainly seen it work as well.
Great, thank you. What's your advice for patients who are tapering opioids?
So long-acting medications are the best. So let's say somebody's on oxycodone. So say the patient in the slides who's on 240 milligrams a month, taking it multiple times a day. I'd want to get that person off of those and onto, say, buprenorphine. And then I would want to taper that person slowly off the buprenorphine. The reason to do that is you got to think about opioid receptors like a light switch. So you're turning it on and off, on and off, on and off, on and off. And so that's really reinforcing, and it becomes very problematic neurobiologically to try and tell the patient, I want you to go from 4 times a day to 3 times a day to 2 times a day. That becomes almost impossible for somebody to do. If you've got that kind of self-control, that's like really impressive. And people have that, but like that's in my neck of the woods, it doesn't happen that often. So we would turn the person off onto something like a buprenorphine, or we might even put them on the methadone clinic, taper them off. That becomes a very easy, structured way to do it.
Great, thank you. Can you speak a little bit about injectable buprenorphine compared to oral buprenorphine, and how would you use one over the other?
Absolutely, great question. So the Achilles heel of buprenorphine is that it's sublingual. It's sublingual because it's 90% first pass hepatic metabolism. So one of the big problems patients have is they'll put it in under their tongue. I've seen this all the time. Put it under your tongue, you drink your coffee. Oh, great. It was in my mouth for 5 minutes. No, you just swallowed all of it. It doesn't work. So when we put people on Suboxone, you got to spend a lot of time teaching people, showing people how to do it right, or it doesn't work. So I see the injectable kind of in 2 ways. One is going to be somebody that you're worried about diversion, all right, because you're going to get it in the person. They're not going to sell their strips. I see another application for people who are really struggling with holding it in their mouth long enough. The concern that I have, so that those are the pros. The con is if I'm trying to get you to see, say, a therapist every week, or I'm trying to get you to come in every week to meet with an adherence nurse, or make sure you're taking your HIV therapy, or you're doing your Hep C workup, or you're seeing oncology, you may not be as motivated. We use buprenorphine all the time as contingency management. So we'll say, hey, you know what? You're coming back next week anyway to see the podiatrist or to see the whomever. I'll give you a week's worth of Suboxone this week. We'll see you next week. We'll get you some more. So you lose that if you're trying to do things more consistently or in short term. So those are the pros and cons, but I definitely think there's a great role for it.
Great. How do you account for people who use amphetamines whose chronic pain goes away when they're sober off amphetamines?
So if they stop amphetamines, they feel better?
Yes, that was the specific audience question, although I have also heard the opposite, that people say they use amphetamines to treat their pain. Any thought about amphetamines and pain?
Yeah, so amphetamines, so all of the drugs of abuse, so, cocaine, methamphetamines, amphetamines, opioids, all cause a dopamine release in the nucleus accumbens that is basically like orgasm times 10, right? So it's like incredibly pleasurable experience. And so when you're having a lot of pleasurable experience, other things kind of drift away. So it's not that the pain went away, it's that your perception of that pain has been muted, right? So if that makes sense. So it's not a good treatment for pain by any stretch of the imagination, especially given the abuse liability. But what I would help patients understand is you've just distracted yourself from the pain, which tells me that we could find some other way to distract you. So let's think about other treatments that don't involve stimulants that are bad for you. Let's find a new way to help distract you from your pain, which is what Lamaze is. Like, I mean, there are a lot of long-term systematic ways to distract oneself from pain.
Great. We have time for one more question. Here's an audience question. Can you talk about the patients who are on long-term methadone, and I guess you could replace that with buprenorphine as well, who don't get tapered? So this audience member said the vast majority of the people he or she is aware of do not get tapered. Why do they stay on that medication? And, is there any harm for that? Should we really push tapering?
So I would liken, so the short answer is there's no problem, right? So we don't worry about it. The real question is everyone's on a spectrum. And so you're going to have a certain group of people who taking them off methadone at any stage is going to be bad. So we take care of paranoid schizophrenics with HIV Hep C, who, if the only stabilizing factor in their life is methadone, it helps their adherence, it helps them stay sober. Taking them off of it is disastrous. Then we have people who are like, 30, no medical problems, whatever. And we're actively trying to get them to get off of methadone. So what I would say is it's not as though everyone should be on it forever or everyone should get off of it. It really should be evaluated case by case. And what I tell patients is always stay on the medicine as long as the benefits of the medicine outweigh any negatives. What are the negatives? Well, one negative is, people call methadone liquid handcuffs, and they call it that because they're just travel restrictions. You want to go to certain places in America, you can't get easy access to methadone. You got to do guest dosing. So it can be a total pain. So one is kind of a restriction on liberty. The other is the main metabolic consequence for it, and not just methadone and buprenorphine, but all opioids, is that it will decrease testosterone. And that's already an issue in people with HIV. And so that's something that you have to monitor and replace over time because individuals will obviously get depressed if they develop hypogonadism. So those are the big things. I used to work with that's also who took care of the original cohort of people on methadone who were started in the 60s. And some of those patients had, I was talking to him in the early 2000s, and some people were still on methadone, had been on methadone for 40 years. And he'd show a picture of them and it's like, perfect teeth, they look great. And he would say, well, how many of them do you think got HIV and Hep C? I'd be like, I don't know, more than half. He'd be like, none of them did, because they were all sober, not injecting drugs when HIV hit New York City. And so the big piece there is don't push someone off of methadone or buprenorphine too early. It does prevent HIV infection by preventing injection drug use. It can be incredibly stabilizing. And oftentimes methadone clinics can become families of social support for people who otherwise have no support in their lives.
Great. Excellent. Thank you so much, Dr. Bruce. We really appreciate that very relevant topic.
My pleasure. And if I know we probably can get to all the questions, but if people email me at robert.bruce@yale.edu, I'd be happy to give a stab at anything that I missed. Thank you all. And again, it's such a pleasure to talk to all of you. The work that you do is incredible. And I know that our patients who use drugs in particular are very challenging. And my thanks to all who put aside personal preference sometimes and work diligently to take care of all people with dignity and respect. So thank you.
Thank you, Dr. Bruce.